Hypertension Awareness Series Episode 20. Common antihypertensive medications, their doses, side effects, and contraindications. This is an important episode where we learn about the drugs that we use for hypertension. We have already covered in episode 19 the stepwise pharmacologic treatment of hypertension. Let's now talk of the individual drugs, their doses, side effects, and when to avoid those drugs. We start with class number 1, the calcium channel blockers or the CCBs. We said the drugs here you use is amlodipine. Amlodipine, you start with 5 milligrams to a maximum of 10 milligrams once a day. For nifedipine, you should use nifedipine long acting, 30 milligrams with a maximum dose of 90 milligrams once a day. What are the side effects of calcium channel blockers? You watch out for pedoedema. Patients may complain of headache and palpitations. Pedoedema and palpitations is more especially with nifedipine. Remember, the edema is dose dependent, and combination of CCBs with ARBs reduce the edema. So note, for CCBs, watch out for pedoedema and also palpitations, and these are more with nifedipine. What are the contraindications? You do not use CCBs in severe hypotension or in patients with acute decompensated heart failure. The next class of drugs is thiazide and thiazide-like diuretics. The commonest drug we have is HCTZ, which you use at 12.5 milligrams to a maximum dose of 25. Chlorothalidone, we use at 25 mg, maximum dose of 50 milligrams. Idapamide, 2.5, maximum dose 5 milligrams. Remember, with thiazides, the main side effects are electrolyte imbalances. They can cause low potassium, low sodium, increased uric acid, and remember, with hyperuricemia, thiazides should not be used in patients with gout. So monitor your electrolytes in patients with thiazides. You need to check your sodium, your potassium, and in case you see hyponatremia or hypokalemia, you may need to stop your thiazide diuretics. So contraindication, thiazides should not be used in patients with gout, patients also with severe hyponatremia, obviously in severe kidney failure. The third class of drugs is ACE inhibitors. Examples are enalapril, we start at 2.5 to a maximum dose of 20 milligrams. Lisinopril, you can start at 10 mg to a maximum of 40. The common side effects of ACE inhibitors is hyperkalemia. Remember, they are potassium-sparing diuretics. They also cause a dry, irritative cough. Your patients keep coughing. They have to keep clearing their throat. Remember, they can also increase the creatinine. And another major side effect is angioedema. So any patient with a history of angioedema should not be put on ACE inhibitors. Those will present with swelling of the eyes, can have swelling of the lips, and also the tongue, angioedema. Contraindication, ACE inhibitors are not used in pregnancy, in bilateral renal artery stenosis, or in patients with history of angioedema. Please remember, for ACEs, you need to monitor your UECRs. A creatinine rise of about 30% is acceptable. Don't get worried if you see a rise, but get concerned if there is a more than 30% rise in creatinine. Remember, we said for patients with renal artery stenosis, one of the clues is markedly elevated creatinine after starting your ACE or ARBs. So that was your ACE. Class number 4 is your ARBs. ARBs do not cause a cough. The commonest example we have is losartan. We start at 50 milligrams, maximum dose of 100 milligrams. You also have telmisartan. We start at 40 mg with a maximum dose of 80 milligrams. Remember the side effect. These are potassium-sparing diuretics. They will cause hyperkalemia and also an increase in creatinine. Once again, they are not used in pregnancy and in patients with bilateral renal artery stenosis. Remember, ARBs do not cause a cough. So a patient with a cough on ACE, you can switch to ARBs. Once again, you have to monitor your UECRs. Please note, you never combine ACE inhibitors with ARBs. The fifth class is beta blockers. Beta blockers, the common we use for hypertension, we have carvedilol, which is easily available. We start at 6.25 milligrams twice a day, up to a maximum dose of 25 milligrams twice a day. You can also use metoprolol, which we start at 25, and metoprolol you can go even up to 400 milligrams. Atenolol is also a common drug that we have for hypertension. You start at 25 milligrams once a day to a maximum dose of 100 milligrams once a day. What are the common side effects with beta blockers? Beta blockers, you watch out for bradycardia, low pulse rate, and if your heart rate goes below 55, you may need to stop the beta blockers. Also watch out for hypotension. A number of patients may experience fatigue and dizziness. Contraindications: beta blockers should not be used when the heart rate is below 50. So patients with heart rates below 50, patients with heart block, second degree, third degree heart block should not be put on beta blockers, and patients with severe asthma. Please note, in the terms of beta blockers, we said those are drugs from number 4 in step 4 drugs, but they can be used at any stage, especially in patients with heart failure, in patients with arrhythmias, and then monitor your pulse rate for patients with beta blockers. Class number 6 is the MRAs, mineralocorticoid receptor antagonist. We said this is a drug used in step 4 and mainly used for patients with resistant hypertension. Here we have spironolactone or aldactone. We start at 25 milligrams once a day to a maximum dose of 50 milligrams Aldactone, you start from 25 milligrams once a day to a maximum dose of 100 milligrams once a day. The other example in that class is eplerenone. We start at 25 milligrams to a maximum of 50 milligrams twice a day. We also have now the newer drugs, the finerenone, the non-steroidal MRAs. The common side effects here is hyperkalemia. They are also potassium-sparing diuretics, so they cause hyperkalemia. Please note, especially spironolactone is associated with gynecomastia, enlargement of breasts in males. They can also cause dizziness. They should not be used in patients with significant hyperkalemia, potassium of more than 5. You should not use your MRAs. They also cause, in the side effect, can also cause dizziness. So note, the key thing with MRAs, you monitor your potassium closely. If it's in a male, keep asking about breast tenderness. Have they noticed enlargement of the breast? And are they also having tenderness and also enlargement? And remember, MRAs are very effective for resistant hypertension. So those are your common drugs that you use and their doses. This is a chart that you can refer to. Remember, we said initiation of drugs, combination therapy from the word go, up titration to maximum doses. That's why it's important to know the maximum doses. Know the common side effects so that you can watch out. You can watch out for the side effects. And always when your patient comes from the word go, drug combination, whenever you are reviewing, ask for the side effects and then adjust accordingly. Then always monitor the labs, the electrolytes for the thiazide, the UECRs for the ACEs and MRAs, and ask the patient directly, are you having a cough? Are your legs swelling? Is there any breast tenderness? So always screen for those side effects. And remember, hypertension is treatable, controllable, and complications can be prevented. We need to know our drugs, we need to know the doses, the side effects, and also when not to use those medication. So do not miss my next episode where I discuss what drug, choosing the right drug for the right patient, hypertension with comorbidities, or what we call compelling indications. Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.